Okay, so so far we saw the epidemic in this century. So let's see how the global community responded to these problems. So could you raise a hand? So if you think our global community responded in a fair way or unfair way. So if fair way means more resources. We provide more resources to the to the countries more seriously affected by the epidemic. So in a fair way or unfair way? Oh, no response? Okay, so how about so they responded swiftly or slowly? So swiftly, slowly. Okay, so it's okay. So yeah, actually, the global community responded not very fair way, and also it was very slow. Okay, so this is a slide graph, presented in the world, AIDS in the world. So this is a number of people, living with HIV. So you will see most of the, people with HIV are living in the low economy countries. So this is the money resource used for, HIV treatment or prevention. Most of the money are used in the high economic countries. So it's a very unfair way. It's a very biased way. So this is called, 10-90 gap. It's not only for HIV, but also it had been for other diseases. So, at the almost the end of the last century, so, resource was allocated in a very unfair way. So this graph shows the estimated access to antiretroviral treatment as of the end of 2001. I said that ART was discovered in 1996. So at that time, most of the patients in most of the developed countries is enjoying access to the very effective treatment. So at this year, the 1/3 of patients who need treatment receiving the drug, but in other regions, only invisible proportion of people are getting access to ART. Only exception is Brazil. So Brazil is a very specific country in the history of AIDS. It decided to produce a generic drug violating the intellectual property, of the drug. So because they thought it is a public health emergency of the country, so people have to get free access to drug to keep their health. So that's why we have some access in Latin American Caribbean region. Okay, so this slide shows the change of the price of the ART, between the 1998 to 2005, only 5 years. So you see, in 1998, it is in Uganda. The price of the first line ART is 12,000 US dollars. So please imagine, half of the people are living $1 a day. So $12,000 per person is kind of astronomically, too high. So it is perceived too unfair, to continue. So then, UNAIDS started a drug access initiative, then started to negotiate with the pharmaceutical company. Also, in Brazil, as I said, they started the production of generic drug. So now, the major pharmaceutical company who actually originally produced the ART is not have to compete with the generic drug companies. So it is started to decline, Then at the end of the 2003, it is already less than 100 US dollars per day. So it is, more than 120 times less than the original cost. So now, it has become realistic to provide the drugs to more people. So this is what happened, around the turn of the century. So in 1996, UNAIDS was established under the general director of UN. So, Peter Piot is the founding director, and he's actually my friend. He every year he comes to Kyoto to stay with us. He is a very key person to all the changes, after that. So in the year of 2000, so MDG was declared, and G8 Okinawa Initiative was issued. Also, the UN Security Council declared HIV as a human security issue. So usually human security issue is a war, but for the first time in the history of United Nations, it declares the AIDS, one disease, as a human security issue. So then Gates Foundation is created, and then in the year of 2001, so there was UN General Assembly of special session, specifically focused on HIV/AIDS. Then, they issue the declaration showing the agenda toward the year of 2010. Okay, so also Global Fund was created in the year of 2002. The PEPFAR is an initiative by President Bush of USA, allocated huge money to the global, AIDS program. So then, because of these, activities and movement, the resources available to low and middle income countries increased. So, access to ART increased very sharply from, less than 0.3 million at the beginning of the century to 17 million, in 2015. It is almost half of the people who need drug now receiving the treatment. It is a, remarkable progress, isn't it? So because of this, AIDS-related deaths started to decline on the global level, and new infection started to decline because of the treatment. Can you imagine why, new infection decline because of the treatment? Treatment is to the patient, right? So new infection is not to the patient. Why it affect the ART affect new infection epidemic? So answer is in this slides. So this is the trend of the ART and then trend of the new infection. So in Canada, it is because of the suppressed viral load in the patients because of the treatment. So ART decreases dramatically the level of virus in the blood. So even they have a risky sexual behavior, the probability to get infect other people will decrease. So it is now said that treatment as prevention. Okay, so because of the expansion of ART, so the life expectancy started to increase again, bounce back to the original level. So it's a good news, isn't it? Okay, so the question is, what will be the future of HIV/AIDS epidemic? So it is very optimistic, or some pessimistic, or how can we solve the problem, whether we can solve the problem or not. So this slide summarizes what happens in this century. So price of the drug sharply declined from $7,000 per year to less than $100 per year from 2000 to 2003. At the same time, the annual resources available for HIV/AIDS in low and middle countries, escalates this way. So because of this, so we can provide the drug to more people. So now, reaching, as I said, 17 million people, about 47% of people who need drug have access to the treatment. So because of this, AIDS-related deaths declined, and then new infection also declined. So looks, very good. But the problem is we are too much dependent on the drug. So if drug becomes, getting not effective, so we have to go back to, go back to history. Unfortunately, as I said, HIV is highly mutable. So it soon easily develops the resistance to the drug unless patients take the medicine very, exactly as prescribed. So it is said we can miss the medicine only 5%. In other words, we have to keep the prescription up to 95%. That means if we have to take medicine 3 times a day, we can miss only 1 dose in a week, right? It's so, we have to keep very strictly the regimen. But unfortunately, the adherence to the drug treatment is not very easy. So this is what is actually happening. in the African countries. So of course at the beginning, adherence is perfect, 100%. But 1 year or 2 years later or 3 or 4 years, so it gradually declines to 70% or 80%, even to less than 60%. So that means that the resistance to drug is growing, in these regions. So why do you think, drug is free, but why they cannot take, medicine as prescribed? Is there anyone who can answer the question? Drug is free, no problem. Maybe some of you think that maybe the cost to travel. So maybe people living far from the clinic have to take a bus or taxi to go to the clinic. But because they're too poor to afford it, they may not be able to, attend the clinic. That may be one reason. Is there any other reason you can think? So our answer is not in the print. You have to think. So the other reason include, cost for testing. They have to be, clinically monitored in the level of CD4 or viral load, but testing is very expensive for them, so they cannot go to the hospital, the clinic. That's the reason. So also, some people, taking the medicine secretly from the family or in their workplace. So sometimes it will be difficult to, take the medicine because of people, surrounding them. So, this one of the topic we conducted research in Africa. So next slides show the paper published by a group, especially Patu Mashika Musmani is our assistant professor. He's going to give a lecture next time. So, he conducted a so-called mixed method study, combining qualitative approach and quantitative approach. So he found unexpectedly, he was working in the hospital of the Congo. He should know, about the reason of the adherence, but he unexpectedly found that they are not taking drug because they have nothing to eat. They have drug, but they have no food. That's why they say they can take drug. So according to the interviews, people said that if we take the drug without eating anything, it causes a very severe stomach pain that they cannot tolerate. So that's why they don't take medicine without food. Also, they are instructed by the medical doctor to take it after meals. If no meals, no after meal. So they don't take medicine. So there's, misunderstanding, but this is real. So in the next, quantitative study, so he surveyed 900 HIV patients, then found 60% of them are food insecure, and 20% of them are very poor, ART adherence. The food matters. So when we think, future ART treatment, we also have to consider how to secure the food, to those people. So if people do not take drug as prescribed, it's easily develop resistance. So this article, titled "Global Threat from Drug-Resistant HIV in Sub-Saharan Africa," and warns that it would be the real, danger. So in this paper, they, reported that almost 10% of new infection is by the resistant virus already. Also, that prevalence is growing year by year by the rate of amazingly 30 or 40% every year. So it is on the increase. Okay, so I said if we depend too much on the ART, so if now the drugs they are taking is a so-called first line ART. First line means the early drugs. The price is much cheaper than others. But as I said, and resistance to the first line ART is growing. So so that means the gain we achieved is decreasing this way. But I say okay if the price of the second line or third line, fourth line is as low as the first line ART, it's okay, no problem. But the problem is they are very expensive. So the second line ART is 3 times more expensive than the first line. That means if we replace all first line drugs with the second line, we need 3 times more budget globally. It is impossible. Also, third line is 15 times more expensive than the first line. So it is unrealistic that we can provide the drugs in such a cheap price. Okay. So this is the final slide. So what do public health specialists, this is us, have to do with this problem? For the solution of this problem, on one hand, we have government or even agencies responsible for the policy and program. So on the other hand, we have people who are responsible for their own behavior and health. So in this spectrum of the responsibility, so what role our public health scientists or specialists can take? That is a question that I have been constantly asking ourselves, and that is how we developed social epidemiology during the last 20 years. So last year, in June last year, that I had the opportunity, I invited to the TED session to present. So I talked under the title of Prevention in the Real World, Social Epidemiology. So I hope you will have a look at it. Thank you very much.